Thank you so much for the invitation to speak. It's a great pleasure to be here, and I've really enjoyed hearing about all the research that's being conducted today, and taking part in the discussion just now has been great as well. So thank you very much. So my presentation is around implementation science for palliative care, thinking about developing an inclusive approach to doing research that makes a difference. I would give a quick run-through of implementation science. I'll introduce the MRC Complex Interventions Framework, because I think that's a very important thing for helping to understand implementation science and the research that we do and how it intersects with research more broadly. And I'm going to tell you the story about a particular example of a study in delirium prevention and management. And then I'll leave a little bit of time at the end just to reflect upon how we can develop implementation research and careers in palliative care. So our usual starting point as an implementation scientist is to go to the definition that was in the launch of the Implementation Science Journal in 2006. That journal was launched on the basis that we needed to address this widely quoted 17-year gap between the creation and the utilisation of research evidence. And it's defined by Eccles and Mittman as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, so as to improve the quality and effectiveness of health services. So in other words, implementation science is doing the research to better understand what we need to do to get research into practice. Now, that can never be a solitary affair. And Bauer and colleagues set out how doing implementation research usually requires transdisciplinary research teams that include members who are not routinely part of most clinical trials. I think they're a little bit disparaging of clinical trials here, but anyway. But anyway, Bauer and co are very clear that, that you need health services researchers, economists, sociologists, anthropologists, organisational scientists, and to do the research in partnership with those who are the other stakeholders. So they name administrators, frontline clinicians, and of course patients. They don't mention carers, but we'll cut them some slack on that. But obviously that is very important too. But we will find in implementation science that the challenges for doing implementation research just go often far beyond this. There's quite an alluring simplicity about the phrase of getting research or getting evidence into practice. And that leads us to think Per Nielsen has written very clearly a lot about how important theories and frameworks are within implementation science. In order to help us to structure our inquiry, what we do, so that we don't reinvent the wheel, and so that we have a way of conducting research that helps us to get under the surface of what is going on. And latterly, the field has been moving much more towards mechanism-based explanations about how you get research into practice. So if all this sounds a little bit highfalutin or abstract when we're talking about theories and frameworks, you can also just reduce it down as well to much more. Implementation science is basically about the interventions, what you're doing in practice, how that interacts with the people who are being cared for, or the people who are, say that's patients or carers, how it interacts with healthcare or social care or other professionals, and how the way in which they interact together, whether they're in a team, within a network, within an organisation, impacts upon implementation and the use of research evidence. And the important part of that as well is that we can actually develop strategies to help facilitate this use of evidence. But it is also useful to reflect as well, is implementation science actually a science, or is, as Wilson and Kisloff have suggested, just a useful umbrella term that gives coherence to an inherently interdisciplinary applied research field. I'll leave you to chew on that one. So yeah, enough of the highfalutin stuff. I think it's time for a cartoon. I think this sums up the importance of implementation science in many ways, because this prehistoric couple, they've somehow contrived to design this incredible TV and this wonderful technical marvel, and then they're saying, but we have no electricity. And I think this is too often what we do in practice or in research, is that we design a perfect intervention or design a perfect, what we think is a technically perfect model of care, and we test it and refine it, and then we don't think about how it's actually implemented or could be implemented. So in the discussion just now, I was saying about think about implementation from the very beginning, and I think that emphasizes that. Very helpfully, the MRC revised their complex interventions framework a couple of years ago. And I think this is a very important framework to understand and use to help structure and think about how the research that we do contributes to the wider, whether within a program of research or in interaction with other pieces of research. The MRC framework is really important, and it was developed in recognition that that complex intervention research that's driven primarily or only by an effectiveness question can fail to deliver interventions that are implementable, that are cost-effective, transferable, or scalable. And this framework is valuable as well for the way that it's moved away from a linear progression from one stage to another, to one where there are phases of research around development of interventions, feasibility, evaluation, and implementation. And it's very clear now that it's not a linear process from one end to the other with that, but that there's a going backwards and forwards between those phases. They're also very clear, again, that early consideration of implementation is really important, that it needs to continue to be considered throughout each of the phases of research, and that transferability of research findings to other settings is likely to require flexibility. And this is where they usefully highlight that it's the underlying functions of an intervention or an implementation strategy that are really important to understand. So when I was thinking about this presentation, I was thinking, well, what studies do I want to tell you about that we've done in palliative or long-term care, specifically around implementation. So I thought, should I tell you about the qualitative research that we did around the implementation of person-centered outcome measures, or the narrative review that we did on the barriers and facilitators to the use of opioids for persistent breathlessness, or the systematic review that we're doing around the palliative care within intensive care units, or the use of the handheld fan for persistent breathlessness, clinicians' views, or even work that we've done that's outside of palliative care, but which is still relevant. For example, this research review that we conducted in conjunction with the University of Surrey around understanding how to address unprofessional behaviours amongst healthcare staff. And I thought, if I try and get through all of those, it's just too much. So I'm going to just focus on one study. This is our detection, assessment, and management and prevention of delirium guideline implementation study, or DAMPN-D for short. And I think it's useful I'll tell you the story about this because it gives me more of an opportunity to show how one research method alone is rarely enough, and that the strength of an implementation study such as this comes from the judiciously using those different methods and ensuring that they speak to one another. It also gives me an opportunity to talk a bit more about the process and the challenges of doing implementation research. I'm not really going to focus on the results of the findings of this study particularly much. I'm more going to talk about the process. And also just briefly say how it can help to underpin further research. So, yes, so I mean, as I'm sure you're aware, the managing and indeed preventing delirium in palliative care settings is hugely important, because the experience of delirium not only can shorten survival times, increase healthcare costs, it is hugely distressing for patients, for carers, and indeed for staff, both clinical and non-clinical. So to get to better understand how we can implement clinical guidelines that have been shown to improve the assessment, management, and prevention of delirium is an important implementation question to ask. So we had 3 work packages in this study. The first was an experience-based co-design work package where we took an existing intervention that had been used in acute settings, and we asked what are the core and adaptable components of an implementation strategy for guideline adherent delirium care in hospices. And we worked with our group of hospice staff, both clinical and non-clinical, and patients and carers to adapt that. Second work package was a feasibility study, which we explored whether it was feasible to collect sufficient outcome data. That's both implementation data and health outcome data from clinical records. And the third work package was a realist process evaluation to explore how the implementation strategy that we were developing could be operationalized in different hospice settings. I talked very briefly at the start about the importance of frameworks, and we actually used the parish framework before we even started those work packages. I don't want to rush through explaining that, but in short, we did a very rapid, non-systematic review of a number of key papers that had explored the barriers and facilitators to implementing delirium care. And the parish framework gave us a set of questions and a structure that enabled us to quickly get a grip on what the challenges were for implementation. So for example, so just picking out a couple of examples here, it allowed us to get a grip on what people's motivations were for engaging with guidelines around delirium care. And this is important because it made it clear that there was an open door in many senses here, and that healthcare professionals often did see a need to change practice. The nurses in particular were driven by a desire to improve care, and they acknowledged the limitations, their own limitations in knowledge about delirium care, recognition and management. The parish framework as well was really helpful because it enabled us to not only focus on individual practitioners, but to think at the team level and to ask what collectively was the understanding of and the perceived need for change. But this was actually far less clear within the literature, so we knew that we had to cover that in our workshops much more. Parish framework also helped us to get a grip on what people's ability to change as individuals were in terms of their behaviour. So, for example, the first question here was around, do people understand the intervention and have relevant knowledge or skills to deliver it? And it was very clear from our rapid review that nurses, for example, could see how informal assessment of delirium could take place in routine practice, but not how that they could use structured assessment tools. And it was that move to structured assessment tools such as the 4AT that was really important for more rigorously and accurately identifying delirium in a timely way so that action could be taken. So moving on to the co-design work packages. So we actually helped to underpin these. We actually used so our starting point was an intervention that had been developed by Jackie Bridges and colleagues at the University of Southampton called the Collaborative Learning Environments for Compassionate Care, or CLEC for short. And this was based on workplace learning theory. Now, this is not badged as an implementation theory, but actually it's hugely important for providing the foundation for the implementation strategy that we wanted to adapt, because it moved us. It articulated the way that workplace learning is not only about transferring knowledge to individuals about how to better identify and manage delirium, but about the work environment in which they are, in terms of leadership, in terms of the support that they get from colleagues and staff, in terms of the opportunities that are provided for people to reflect on their practice and to think about how it might need to change in a way that is a safe space to do that. So here's a real sort of implementation challenge. Lifting it from the individuals concerned to the environment in which they work. So it's a different way of looking at things. Another aspect of that workplace learning theory as well is that staff needed to be able to feel free and able to express their emotions and ideas, to be open to considering others' perspectives, and being confident to ask curious questions. I remember earlier today we were talking about just doing things because that's the way it's always been done. It's always been done like that here. We've been doing it this way for 20 years. So there's a really, in terms of implementation, there's a real important step to take for clinicians to move from that and to feel confident and supported in that. So this was a really important theory that underpinned the implementation strategy that we were developing. I'm just going to very quickly click through this slide. This is I know it's probably too small and there's far too much information to read on that, but it's just mapping out the way that each aspect of the theory was then operationalized within the CLEC implementation strategy. Oh, and that's we used the tidier framework there. It's a very useful, straightforward framework for spelling out why, what, who, when, where, and for how long each component of an intervention or an implementation strategy is. It obliges you to articulate things, and that's good. So, yes, so this is a real scamper, really, through the various aspects of the three work packages. So as I said, we had our work. We had a series of 3 co-design workshops held with people with experience of delirium or for experience of caring for a person with delirium, as well as the health and social care professionals from within the hospices. And this enabled us to get feedback and to work with our stakeholders in the workshops about how the various aspects of the implementation strategy needed to change to make it appropriate for delivery for use in hospices. And a lot of these were around the aspects of the study day. Some parts were superfluous and were just not necessary for use in hospices. Others needed to be adapted to so that we had some that were delivered online, some delivered in person, and so on. But really importantly as well, they also spelled out, those workshops really helped us to identify the importance of making space in those study days for the hospice teams to sit down together and actually think and work up the details of how they were going to implement the guidelines and use the implementation strategy in practice. So there was a real facilitative role that the study days needed to play there, and the co-design process helped us to identify and develop that. The second work package was the feasibility study, and this is a much more conventional work package in terms of that it was assessing the feasibility of collecting data, and could we do this on a larger scale in a powered trial? And the short answer is yes, the larger study was feasible. The data extraction, the patient data extraction tool was 100% completed, 50 inpatient episodes in each of the 3 hospices. We managed to achieve a true consecutive sample, and no patients or their representatives elected to opt out. We were also able to collect feasibility data about the extent to which hospices were using the implementation strategy. So the parts along the top here, the mid-shift cluster discussion, observation of practice, etc., are all the components of the implementation strategy. And we were able to say, to monitor here how, for example, Hospice 2 was not using all of the components in the way that they were intended, whereas other aspects such as the mid-shift cluster discussion were being adapted by each of the hospices to be used in a slightly different way, but a way which was consistent with the function that was intended. And we were also able to collect cost data from each of the hospices about the time and the cost required to enable staff to take part in each of the aspects, each of the components of the implementation strategy. And I know there's just XX there. This is currently under peer review, and we're not in a place to share that data just at the moment. But we were able to collect it, and the importance of being able to accurately cost accurately cost the implementation of an intervention is hugely important for making a convincing case for its use. And in the third work package, I'm just going to tell you about the survey here that in which we used Carl May's normalization process theory. There's an existing survey called the NOMAD survey that we're able to use that explores the extent to which staff feel familiar with or prepared for to use a new intervention or to use an implementation strategy. And if I just whip through those, what the most important thing to recognise here is that, again, this helped us to identify the areas in red, these areas around, communally specifying. So as a team, understanding what was involved, and the extent to which they could work together as a team to use the implementation strategy. So these areas in red identify those areas which the cells in red identify the areas where there were weaknesses, and we were able to take that back into the co-design workshops as well, in an iterative way, so that we were making use of the emerging findings from the work packages to feed into what needed to happen within the implementation strategy itself. So I said I'd just tell you a little bit about the challenges in the study and what went wrong. So I mean, there's this was a large part of the study was taking place during COVID, and there were there was significantly reduced capacity within the hospices, and there was closure to admissions in one or more of the hospices at various points, which had obviously large implications for the number of patients who were being cared for, and therefore the amount of data that we could collect. We also had challenges such as our lead researcher testing positive for COVID the day before an in-person study day, which meant that we had to rapidly rejig what we were going to do. But I think we didn't really experience these as challenges, but I think we had a different mindset in a way from what we might have had in a conventional clinical trial. What was I going to say? So we didn't really see these challenges. We didn't really see these challenges as aberrations that were going to trip us up. We just, or that were going to make a mess of the whole study. But they were just the reality of 5 minutes here. Okay. Just the reality of delivering care, and so we were able to quite rapidly pivot and be flexible in our approach. We were mentally in the right place to do that. The co-design workshops themselves were developed with the public involvement member of our team, and we co-facilitated with this person as well. But our learning from this was that this could be overwhelming for the person to do, even though they were very keen to be involved and they wanted and they volunteered to co-facilitate. So I think our learning from that is that sometimes you need to hold back on that or explore in more detail what is actually involved in that co-facilitation before storming ahead with it. Interestingly, sometimes we found that the public involvement members in the workshops were more familiar with the format and were more willing and able to speak up and contribute than some of the hospice staff. So that was a surprise to us, and I think in the future we'd take more effort to ensure that the hospice staff were confident to contribute throughout. And we had challenges with expecting some staff to collect fidelity data. We need to do that much more manually in the end. But we did manage to keep the hospices involved and engaged throughout the research. And I think one of the key reasons we managed to do that was simply that we were addressing a challenge that they recognised and wanted to they could see the reason for being involved, and they could see the reason for addressing that challenge. And they could, and through the newsletter as well, we were able to make it clear to people how this was part of a broader field of research and one that could progress to future studies as well. And we paid attention to cultivating and maintaining those relationships with members of staff from the bedside and up to board level, because that was so important for maintaining that engagement in the research. So I know I'm running, is that happening? No? There we go. And I've got only a few minutes left, and I do want to get to the, just thinking about developing palliative care research careers. So I think this reflections on doing the implementation research is, yes, we need to be flexible, proactive, and pragmatic in what we're doing. And there may be a significant role as well in educating other team members about what is involved in implementation research. I do think implementation theories and frameworks are important, but they're not always essential. As you saw, we've used a couple, but then we also used workplace learning theory, which is not a specific implementation theory, but was important to use in this particular study. And we present research as neatly delineated work packages, but But we found that in this implementation research, there was much more iteration between those work packages and interdependency, and that was important to acknowledge. So I'm just going to very briefly reflect on research systems for rewarding careers. So I mean, I was really pleased to read the Institute's strategic priorities for the research network, and there's two of those strategic goals that I particularly want to just quickly focus on. The first was that creating an academic clinical environment that fosters innovation, and the second was developing palliative care researchers and supporting career development. It's gone blank, right. So I think those are absolutely spot on. I think the plans in the strategy are really clear and worthwhile and great to pursue. But my friendly challenge to you as well is to think about the UK Research and Innovations strategy 22 to 27. Emma earlier on mentioned about boundary spanners, and this touches upon boundary spanning in the sense that it really tries to articulate, to place research careers within a framework of mobility. So this is, I call them braided careers, where people move more freely across different areas of research and practice between different sectors. If you work within a university like I do, you'll know that they're not in that place at the moment, that the expectations are often very highly academic or research focused. So I think there's a real challenge that the UKRI have laid down around developing these more mobile careers. Also, I think that something this usefully highlights is that it can be important to situate research within a broader system. So in the UKRI's words, one that drives economic, social, environmental and cultural benefits for all citizens. And I think maybe sometimes the case for palliative care research, how it can improve public health, is not so clearly made. So I will leave you with that to think on, and thank you for your time.